I'm really excited to share with you some of our recent work. And when I say I mean recent, I really mean recent. These are results from yesterday. Given that we're talking about modeling COVID-19 interventions, I thought it would be best to talk about the most up-to-date possible work that we could. So I'm going to share with you what my lab has been doing to try to understand how COVID-19 non-pharmaceutical interventions can help prevent a major outbreak. So first, I want to begin by acknowledging the fantastic team from my lab. I think several of them are on this call right now. In particular, Marissa Childs and Morgan Kain have really led the charge on this modeling effort, along with Devin, Kirk, Mallory Harris, Lisa Couper, Jacob Ritchie, Nicole Nova, and Isabel Delwel. And everything I'm going to talk about today is available open source on Morgan's GitHub page, which you can see a link to here. I also want to acknowledge the really generous support that we've received from the NSF Ecology and Evolution of Infectious Diseases program, the NIGMS MIRA program, the R35, the Natural Capital Project, and the Terman Award from Stanford. So it's not obvious that this is exactly the story I should be telling here today. Typically, for those who aren't aware of our lab's work, what we usually work on is the ecology of infectious disease. In particular, usually we work on mosquito-borne disease and thinking about how things like climate change and land use change affect the transmission of mosquito-borne disease around the world. So as we were in the process of doing our typical work around early March, mid-March, we're sitting in our beautiful new building, the Bass Biology building, and we're thinking about, what is it going to mean with this outbreak going on? Should we be, starting to work from home? Should we be, social distancing from each other? Should we be washing our hands more often? And, as we were going through this process, it started to become obvious that we were living through our generation's version of the 1918 pandemic flu. And so to be infectious disease modelers and not be spending at least some of our time thinking about COVID-19 felt a little bit like a wasted effort. So we started to try to think about what we might be able to do to contribute to understanding epidemic dynamics. And in particular, by March 11th, we were no longer in this building. We were actually all looking very beautiful on Zoom, having a lab meeting. And we started thinking about what were the really important gaps in COVID-19 modeling that we might be able to fulfill as a lab, coming from an infectious disease background, but not necessarily a respiratory illness background. And a couple of the things that we thought about were thinking locally, so Santa Clara County, which is where Stanford is located, and also thinking about the impact of non-pharmaceutical interventions and modeling these particularly in a sort of qualitative way that we could then use to communicate, particularly with the public, because we knew that there were some modeling groups out there that were really actively involved in informing the public health response and doing day-by-day forecasting models. And often these people that are most heavily involved in the modeling efforts and the policy decision-making don't have a lot of time to speak with the press. So one thing we thought we might be able to do is help communicate about non-pharmaceutical interventions to the public. Of course, at the very beginning, that meant communicating things like flattening the curve. And now, as the epidemic has gone on, we've started thinking about reopening and exit strategies from lockdown. So just as we were having this lab meeting and starting to think about how we could develop COVID-19 models, Santa Clara County became one of the first in the country to announce a shelter-in-place order. So on March 16th, all of a sudden, even surprising us, to be honest, it was announced that we were going to be sheltering in place. We would no longer be working from campus. We would no longer be going to the grocery store if possible. We would be really staying at home. And that really kind of lit a fire under us to start thinking, especially very locally, about what is the transmission setting going on in Santa Clara County, and what are these social distancing orders like shelter in place going to do to reduce transmission? So very quickly, we put together an SIR style model and we parameterized it as best we could. And I'll get more into that in a minute. But our first goal, as I mentioned, was to try to communicate with the public about what social distancing could do. So we created this R Shiny app and put it online and allowed people to kind of play around with different social distancing interventions. And we thought that this would be a simple way for people to get an intuition for how social distancing might slow the spread of the epidemic. Just to warn you, this website is pretty out of date at this point. This is really our first attempt in mid-March to try to understand the impact of social distancing. To our surprise, what happened after we put this website up is we got contacted by a wide variety of different news organizations and public health departments. And really what it appeared is that we had tapped into this kind of unmet need of people to try to understand what social distancing strategies were out there and what would be the impact of these social distancing strategies. So at that point, we went from this being sort of a small short-term project to thinking a little bit bigger about what we could do to try to model COVID-19 interventions. I probably don't have to sell this audience on mathematical modeling, but just in case, two of the things that I think are really cool about epidemiological models are, first, that they make the unobserved measurable. So one of the big issues in this epidemic, as you all know, is that testing has been so limited in the United States that, and many other places in the world, that we really don't even know how many cases are actually out there. We think we have a little bit better of a sense of how many COVID-19 deaths are out there, but even those are probably underreported. So one of the things we need to know is just how many cases, how big is the epidemic compared to how many cases have actually been reported. The other thing we can do with epidemiological models is we can do hypothetical experiments. So we can do experiments to look at how different social distancing interventions, how effective they might be in a given population setting. We can look at counterfactuals to try to understand what would have happened if we had taken different decisions, and so on. So making the unobserved measurable. The questions that we're really focused on here are very basic. What has happened in this epidemic so far in terms of how many cases and deaths, or how many infections, I should say, and deaths have there truly been? What will happen next, depending on what our social distancing interventions are? What should we be doing to control the epidemic? And what is the impact of what we've already done? And to address these kinds of questions, there are two kind of broad general types of models out there. Of course, there are many subtleties on these different types of models, but just to kind of put them into broad classes, the first class is what I'll call compartmental models, which are models that aim to capture the transmission process itself. So contacts between susceptible and infectious people and how that propagates through the population. And these models are generally termed SIR models, for susceptible, infected, recovered, but they can take on a whole lot of additional complexity. So here I'm showing some additional compartments that you can have in the models, and these models can then be coupled across multiple populations to get either network versions or meta-population versions. But in general, all of these models sort of boil down to the fact that they're trying to capture the transmission process in a population. And because they're capturing the actual transmission process, these models are really useful for exploring scenarios and regime changes. So what would happen if we changed the way transmission were happening in our population? What would happen if we changed our policies around social distancing, for example? The other kind of broad category of models are what I'll call curve fitting models. And these are kind of statistical forecasting models that take previous data on the observed quantity of interest, whether it's confirmed cases or ICU admissions or deaths. And by tracking the previous dynamics of that quantity of interest, we can then forecast into the future. And these forecasting models are often best done over short time periods, like 1 to 2 weeks into the future, or up to maybe a month in the future. And the value of these kind of curve fitting forecasting models is that they can give us more accurate numerical predictions. And ideally, they can also give us credible intervals around how much uncertainty do we have around those forecasts. So today I'm going to focus on our work, which is a compartmental model. So again, we're aimed at trying to capture the dynamics of transmission in a focal population. So we're using sort of an expanded SEIR model here, so susceptible and exposed. And then within our infectious class, we actually have it broken down into multiple compartments. So people can be either pre-symptomatic or asymptomatic. So some people we're assuming actually remain asymptomatic throughout their entire infection. We also know that pre-symptomatic transmission is really important in this epidemic. So before anyone becomes symptomatic, they go through this pre-symptomatic but infectious stage, at which point they can then transition into either a severe or mildly symptomatic class. And then from there, the severe infections go into hospitalization, which then either lead to deaths or recoveries. And then all of the infected people can either transition into the recovered or the death class. Oh, the other important thing to note about this model is that we're using a time varying beta parameter, beta representing the transmission rate at which susceptible people become exposed after their contact with infectious people. And I'll get into more detail later about how we're estimating this beta, but just note that this is a time varying beta that varies over time as a function of social distancing. So the goals of this work are first, estimate the transmission parameters for locations of interest using a combination of mobility data, case data, and death data. Next, we want to understand the impact of interventions on epidemic dynamics. Then we can evaluate future intervention scenarios. Then we can estimate the benefits of previous interventions. And I want to also be really specific about what the model is not aiming to do here. Because this is not sort of a curve-fitting forecasting model, we're not really trying to make quantitative forecasts here. We're also not incorporating detailed mixing within the population, demography, metapopulation dynamics, or heterogeneity, although I'll get into a little bit of discussion about heterogeneity at the end. We're also not trying to directly inform policy decisions here. We're trying to give sort of qualitative understanding of what social distancing does, but we're not specifically saying, here's what we think we should do in this particular county. So here's the approach. We're going to start with a number of fixed parameters from the Midas Network, which is the Modeling Infectious Disease Agent Study Network, which is funded by the NIH, as well as some of the literature that's out there, both published and preprint literature. We're then going to specify ranges of particular parameters that we think are uncertain. These are things like the start date of the epidemic in a local location. And then this is kind of the meat of what we're doing with the model. We're estimating these daily transmission parameters using daily COVID-19 deaths, cases, and a cell phone-based mobility metric. What we're doing here is we're actually estimating a case detection function, because of course we know that the cases are highly underreported, especially at the beginning of the epidemic. So we're able to leverage both information on deaths, information on cases, and this independent source of information on cell phone-based mobility. And then we're using those parameter ranges, both the fixed parameters and the pre-specified ranges of the uncertain parameters. And then we're using partially observed Markov processes using this R package developed by Erin and colleagues for this parameter inference. We're then stochastically simulating trajectories of the epidemic. And then we're calculating epidemiological metrics like R0 and R effective. So these are the basic reproduction numbers, or the number of secondary cases produced by a single infectious case introduced into a population that's either fully susceptible or has undergone some epidemic dynamics already. And then finally, we're going to investigate intervention scenarios by varying beta over time. And we're going to explore counterfactuals in this model. So as I mentioned, most of these parameters were derived from the Midas Network. They have a really great online portal that has a bunch of different previously fit model parameters, as well as data, as well as assumed parameter values for important biological parameters. If you have questions about particular parameter values, I can get into that at the end, but I'm not going to go into detail now. So first, we're going to focus on Santa Clara County. As I mentioned before, we got interested in looking at our own backyard. This is Stanford campus, as you can see, on a really beautiful day. Santa Clara County is particularly interesting because we know that we had COVID-19 very early within the US epidemic. And in fact, retroactively, it's now been reported that the first COVID-19 death in the US happened in Santa Clara County on February 6th. Alarmingly, it was a woman who was 50 years old and otherwise healthy and died in her home after community transmission occurred. So it's an interesting location because we had epidemic dynamics really early. It's also interesting because our county public health department did what, in my opinion, is a really nice, resourceful sentinel surveillance study that really gave us a picture of what was going on early in the epidemic. So between March 5th and March 14th, the county public health officers knew that they didn't have enough testing available to test everybody that had flu-like symptoms. So what they did is they started screening patients that came into urgent care clinics with flu-like symptoms. They first screened them for flu, and if they had flu, then they were diagnosed with flu. If they tested negative for flu, a subset of those people were then tested for COVID-19. So of those 79 people that had flu-like symptoms but didn't test positive for influenza, 11% of those people tested positive for COVID-19. And this was, again, between March 5th and March 14th. So that told our county public health officers that we had a substantial community transmission problem going on, and that we should really be concerned about community transmission in Santa Clara County. And that led almost immediately to the declaration of the shelter-in-place order, which again was the first one declared in the country. So the first place we fit was Santa Clara County. And I'll orient you to these plots, which I'm going to show several of over the course of the talk. On the top panel is the daily reported deaths. We can see that that ranges from 0 to about 5 per day. And this is the fitted model. In black is the median in the black line, and then the gray window is sort of a confidence interval, although it's not a complete confidence interval at this point because we're still in the process of running more fitting over a broader range of parameter values. The middle panel is cumulative deaths or total deaths. So you can see that the model is capturing that pretty well. And then the bottom panel is observed cases. So in red are the data, and in gray are the fitted model, confidence interval, and median value. So what this is showing so far is that the model can capture dynamics of the epidemic pretty well in Santa Clara County. And we can now look at the effective reproduction number on top and the case detection proportion on the bottom. So what we see in Santa Clara, as we've seen in a lot of other places around the world, is that the effective reproduction number in February to March was hovering right around 3, kind of going back and forth. And some of these blips that you're seeing are resulting from the blips in the mobility data, which I'll show you in a minute. But we're estimating that that effective reproduction number was hovering between about 2.5 and 4. And then with the shelter-in-place order, which again occurred on March 17th, we see a really rapid and decisive drop below 1. So that's really good news. The shelter-in-place order pretty quickly brought the epidemic so that the reproduction number was below 1, and it's been hovering below 1 ever since, although it appears to be gradually climbing back towards 1. We're also estimating that we're increasingly detecting a larger portion of our cases in Santa Clara County. Just for reference, in this county, there are now 40 free testing centers available. So we do think that there's pretty broadly accessible testing in this county at this point. This is the cell phone-based mobility data that we're using to help estimate these beta values. This is the proportion of devices that are sheltering in place. So we can see that even before the shelter-in-place order, there were some devices that sheltered in place, and that there was a little bit of sort of week-to-week variability in this. And then really rapidly after the shelter-in-place order, as indicated in this dashed line, we saw a lot of devices sheltering in place. And actually, you can see that some of that change happened right before the shelter-in-place order. And that's probably in part because some of the local employers like Apple and Google and Stanford had started to ask their employees to work remotely already. So already some people were not leaving the home as much as they previously were. And we can see that the shelter in place has remained fairly consistent throughout the remaining time up until our current point in time. So we then wanted to look at other interesting locations. It's pretty arbitrary why these are interesting, but they're major cities around the US that are geographically and demographically disparate from each other. Seattle was one of the other places on the West Coast that had early epidemic dynamics. Los Angeles is one of the places in California where we've seen the epidemic continuing to grow, as I'll show. Miami and Atlanta, both southern US cities where they've had pretty substantial outbreaks. We notably shied away from New York because our model in particular is assuming that there's no underreporting of deaths, and we know that in New York there were a lot of underreported deaths. So we're specifically focusing on these other major US cities for now, but in theory the model could be tailored to any US city using the local case and death and mobility data. So here's Seattle, King County. We can see that for this county, again, we're doing a pretty good job of fitting to the daily death data and the daily case data. So here on the left, we see those metrics I showed before of daily deaths getting up to about 10 per day at the peak of the epidemic in April, and daily cases getting above 100. We can see the effective reproduction number, again, hovering between about 2 and 3 for King County. And we can see that that dropped well below 1 by late March. We can also see the detection probability increasing and saturating as estimated from the model. Los Angeles County is a little bit different. Here, I want you to note 2 things about this. First of all, the daily deaths got much higher than they have in other parts of what we've seen so far, at least in Santa Clara County and Seattle. We can see that the daily deaths are getting up to almost 100 in some days. We can also see that the model is not doing as good of a job of capturing the early dynamics of deaths in this particular county. We think that that has to do with probably some underreporting of deaths early in the epidemic, which gave the model artificially high confidence that we were detecting too many of the cases. But nonetheless, the best estimate that we have right now for LA is that our effective was hovering between about 3 and 4 early in the epidemic. Shelter in place, which was declared statewide by March 19th, you can see led to a decline in the effective reproduction number. But in LA, in contrast to Santa Clara County, the effective reproduction number has been hovering right around 1 and bopping just below and just above 1 throughout the epidemic. And you can see that there's a pretty clear trajectory towards a climbing reproductive number in LA. For Miami-Dade County, again, we have this issue with not quite capturing the deaths very well, and I'd love to get back and talk about that later on if people are interested. Although we're now capturing the cumulative deaths and the cases fairly well with the model. We can see that the estimated reproduction number early on was a bit higher, between 4 and 6, and we're not sure whether that's a true difference in the reproduction number in Miami or whether that's to do with the difficulty of fitting to deaths and cases when we think the deaths may have been underreported in Miami. And that's because basically by the time we had hundreds of cases per day, we were still seeing very few deaths reported in Miami. So it appears that there's sort of a difference in lag between the reporting of deaths and reporting of cases in Miami compared to some of the other locations. And then finally, we looked at Atlanta, Fulton County, which is one of the 2 major counties that makes up Atlanta. And we can see that, again, in this case, the model's doing a pretty good job of capturing the dynamics of deaths and cases. And in Atlanta, again, we see the effective reproduction number hovering around 4 at the beginning of the epidemic, dropping below 1 in late March, and then sort of gradually climbing above 1. Of course, as we know, Georgia has reopened as of probably a month ago at this point. So we expect the effective reproduction number to be climbing in Atlanta. In some of these locations, we're starting to see mobility increasing again. Now remember, this is sort of an inverse metric of mobility here. So this is the proportion of mobile devices that are sheltering in place. For Los Angeles on the left, we can see that that went from low to high after the shelter in place order. And we can see that that's now starting to trail off a little bit. There's an even stronger trailing off pattern for Miami and for Atlanta. So somewhat worryingly, we're starting to see that people are going back out and that there's potential for increased transmission, particularly in LA, Miami, and Atlanta. By contrast, the mobility is holding a little bit more steady in both Seattle and Santa Clara County. We can see it's declining a little bit, but not as visually substantially as in the other locations. So what should we do now? Again, we're going to focus on Santa Clara County here because this is our home, and this is one of the places where the model fit is working pretty well. And it's one of the places where the effective reproduction number has been brought below 1. And so we now have some options for what we could do next. But again, these analyses could be done on any of the locations that I've talked about. So here I'm just showing the same model fits that I showed earlier for Santa Clara County. This is daily cases on the left and cumulative deaths on the right. So as of June 8th, as of today, what should we do going forward? We modeled a few different intervention scenarios here. In red, indicating a bad idea, would be to lift all interventions and completely go back to pre-shelter in place. Of course, if we were to do that, we would see a really dramatic and rapid epidemic, as you can see in the red lines here, that would result in a lot of deaths. In orange, we're showing what would happen if we just reduced our shelter in place to 50% of what we're doing now. So you could think of that as increasing our mobility again by 50%. If we were to do that, the effective reproduction number would go above 1 and we would see the epidemic starting to climb. What's more encouraging though is we have 2 interventions that seem somewhat moderate that might actually allow us to control the spread of the epidemic over the long term. The first one I'll talk about is in green. That's, again, reducing our mobility to 50% of what it was during shelter in place, so allowing a little bit more moderate mobility in the general population, but at the same time, increasing our testing and isolation of symptomatic people. So the assumption here is that if we have enough testing capacity, we could cut the mobility of just the symptomatic infected people by a further 80%, and that by doing that, along with a social distancing level of 50%, in the general population, we would still be able to allow the epidemic to decline. That's what's shown in the green. Another alternative that we thought was really interesting is, what if we, again, did 50% of our current social distancing in the general population, but in this case, we cut down the opportunities for super spreading. So what we've been thinking about this here is that if there's a distribution of transmission rate values across people, that is a function of how many contacts they have and how infectious they are when they get infected. What if we were able to chop off that distribution so that we just truncate the tail and we reduce those opportunities for super spreading? So in particular, what we're doing here is we're chopping off the upper 5% of the transmission rate distribution, but otherwise leaving it unchanged. And what we can see is that with that intervention, which is shown here in blue, we're again achieving epidemic control and even a declining epidemic with just 50% of the current level of social distancing that we have in the population. So we're sort of thinking of that as the equivalent of not allowing large gatherings, concerts, ball games, things like that, that might generate the opportunity for super spreading. So the upper 5% of the distribution of beta rates, while potentially allowing other social contact to occur. So the first point here is that continued interventions are going to be critical. Even with shelter in place, the epidemic was only declining very, very, very slowly because our effective is really close to 1. So we're going to need continued interventions until we have an effective and widely available vaccine. The next question I want to ask is, what was the impact of the current interventions, which included work from home, sort of informally, into early March, followed by a shelter in place order in Santa Clara County on March 17th. So to do that, we're doing these counterfactual scenarios where we're adjusting our mobility data as if a different intervention had occurred. So what I'm showing here in gray and black is the reality. So the true number of daily cases and the true fitted model of the dynamics of cases. In purple is the really bad counterfactual. What if we had not done any social distancing? We would have seen a really big epidemic very quickly that would have already peaked and started to turn over. In orange is a really interesting scenario. What if we had just delayed our social distancing by 1 week, which was the equivalent of what New York did and a lot of other places? So instead of doing shelter in place on March 17th, what if we had waited 1 more week until March 24th? This is what the dynamics of the epidemic would have looked like in orange. And then finally, what if we had done the shelter in place on March 17th, but lifted it completely on May 1st? Then again, we would have expected to see the epidemic really rapidly climbing again. That's what's shown in green. So this is shown for daily cases. Now I'm going to transition to looking at cumulative deaths so that we can really start to put numbers on our counterfactuals here. So this is just the number of deaths averted up to June 8th, up to today. So the true observed number of deaths up to today in Santa Clara County is 141. If we had delayed shelter in place by just 1 week, we would have seen an additional 253 deaths. If we had ended shelter in place on May 1st, we would have seen an additional 422 deaths. And of course, that would just be the beginning because the epidemic would still be growing again. And if we had done no intervention at all, we would have seen an additional about 9,400 deaths. And again, I'm just showing you point estimates here because we're still in the process of deriving the full confidence interval, because we're still in the process of estimating transmission parameters over the full uncertainty in the other parameters. But just to give you some point estimates, this really shows the impact of that early intervention that we had. So just delaying shelter in place by 1 week, we would have more than doubled the number of cases that we have actually seen. So it's really important that that early sentinel surveillance study happened and that action was taken very quickly afterwards. Okay, so the key points of what I've shown you so far. Long-term interventions are going to be necessary. So we can see the epidemic is starting to decline, which is what's shown in the gray. But if we were to lift any sort of intervention altogether, we would see a really rapid second peak, and it would be as if we had never sheltered in place at all. So it's important that long-term interventions continue. However, expanded testing is going to allow lighter social distancing in the general population. So that's very, very good news. We've expanded testing quite a bit in this county and in many other places in the country. And what that allows us to do is really target these social distancing interventions just on the people that are most at risk of transmitting, or at least the people that we're easily able to identify as symptomatic. From there, of course, we can get even more gains by doing contact tracing, and then we can perhaps capture some of the asymptomatic spreaders as well. Because R0 is currently near 1, the decline in epidemic dynamics is going to be very, very slow, if at all, in Santa Clara County. So again, this gets back to the idea that we're going to need long-term interventions, and we can't just wait and shelter in place until the epidemic is over, because that would take many, many months. Another really encouraging point that I would like to get out there in the midst of all this discussion about reopening and economic consequences and you know, the urgency that people feel about reopening our economy is that these early interventions really have saved a lot of lives. And the number of lives that have been saved are really quantifiable using these kinds of models. Excuse me. Another really interesting point is that because heterogeneity is a key feature of epidemic dynamics of almost all infectious diseases, we can use that heterogeneity to our benefit by trying to eliminate opportunities for super spreading. We've seen some really clear cases of super spreading taking place on places like cruise ships and nursing homes and exercise classes where you have lots of people concentrated together. And by taking advantage of the fact that a lot of the transmission occurs in these rare super spreading events, we can potentially sort of chop off the tail of transmission distributions by eliminating the possibility for super spreading. A few next steps that we want to pursue now, a student, Mallory Harris, in the lab. I'm actually from Georgia as well, and Mallory is from Georgia. Both of us went to the University of Georgia as undergraduates. So we're interested in the case study of Georgia because Georgia has been sort of the opposite of California in its early intervention strategies. California declared a statewide shelter-in-place order very early on. Georgia, by contrast, had county by county interventions that differed in the beginning of the epidemic. And the statewide order wasn't declared until either late March or early April, I can't remember. And the governor lifted the statewide order very early as well. So in Georgia, we have a patchwork of different interventions that took place. And we're really interested in understanding in the Georgia context, what is the impact of county level government responses on COVID-19 deaths? We're also interested in what is the impact of racial disparities on COVID-19 deaths in Georgia. As you can see, looking at the map of Georgia, it has 159 very small counties. So these are very small sort of local government administrative units that are interesting to explore. The other next step that we're really interested in is thinking about the impact of seasonality in combination with interventions. Many of you may have seen some of these excellent papers that came out in Science modeling the impact of seasonality on transmission. And these papers made the really excellent point, as you can see from the Rachel Baker paper here shown above, because the proportion of the population susceptible is extremely high to an emerging pathogen, even with variation in transmission as a result of variation in humidity, we don't expect to see a really big effect of seasonality. And that's shown again here in the Kistler paper down below, which is basically projecting that we're not going to see a really big effect of seasonal climate variation on transmission. Now, the reason that seasonal climate has an impact on influenza, COVID-19, seasonal colds and flus is because the suspension of respiratory droplets depends on the level of humidity in the air as well as UV and temperature. So the longer these respiratory droplets stay suspended in the air, the more transmissible the virus is, and humidity affects the evaporation of these droplets. So somewhat counterintuitively, at least to me, higher humidity actually reduces transmission because the droplets don't evaporate as quickly. When the droplets drop out of the air, there's less transmission occurring. So what we're in the process of doing now is collaborating with a virology lab, Dr. Stephanie Seifert, who's doing these experiments across different temperature and humidity levels with COVID-19 to estimate how the virus itself, the virus survival on surfaces or decay on surfaces, as well as decay in aerosols, will decline with these different climate conditions over the summer. Now, we're not arguing with the point made in these previous papers that because the proportion susceptible is high, summer climate is not going to save us from this epidemic. But given that our current interventions are bringing the effective reproduction number to very close to 1, we think that subtle variations in climate could actually have a measurable effect on the epidemic dynamics, because changing even by 10% the transmission rate could be enough to bring us below or above 1, depending on seasonality. So over the summer, that's good news, because that means that potentially the impact of climate could slow down transmission in the context of a controlled setting. Unfortunately, that also means that in the winter and the following spring, we may see an uptick in transmission even under controlled conditions because the climate is becoming more suitable. So with that, I'll wrap up and again, show you the links to our work here, and I'll be happy to take any questions.